right, so this is great. I really appreciate everyone being here, and I'm very excited about this conference. It's been a while in the making. I think it's going to be very exciting, and all of you were handpicked to be here because of your knowledge and expertise in these areas. So I'm going to stir the pot a little bit. I've been known to do that sometimes, and sort of set the tone if that's what you want, or raise the questions I've had in my head over the last couple years. I work with a lot of the folks in this room in pharma. Hopefully this will not be you'll take this as a non-biased presentation. So these to me are in the lupus area, in the autoimmune area. These are the two seminal articles that really pushed me to ask the question, and many of us to ask the question is, can we actually cure lupus nephritis? And so the first article came out of the George Schett group in Germany. They presented their 5 refractory lupus patients with lupus nephritis who received CD19 CAR T-cell therapy. And I'm not going to go over CAR T-cell therapy. I think everyone here gets it, how it's done. And every one of them went into remission, and in a very short amount of time with very few adverse events. The first paper was really a New England Journal letter to the editor of one of their first patients, but this really captured our attention. They quickly followed this up with another New England Journal paper, which was the 2-year results of the anti-CD19 CAR T, and they added 3 patients. So 8 patients, 2 years, 100% complete renal response. Okay. In 3 months, no lupus nephritis relapses over 2 years, and now more than 2 years, off all immunosuppression, including hydroxychloroquine. Okay, for the rheumatologists in the room, I don't need to say how profound that is, and for many of the nephrologists in the room who take care of lupus patients, I don't need to say how profound that is. So let's take that apart. I'm a skeptic by nature. I think many of us are, because we do scientific investigation. This was the safety profile of the first 5 patients in the Schett registry. And basically, this may be too tiny to read, but I'll just tell you that it was safe. Everybody did well. Nobody had any problems. There was a little tiny bit of cytokine release syndrome. If you're not familiar with that, you're going to be by the end of this conference, but it can be devastating. These were all grade 1 cytokine release syndromes. And very few people got into trouble afterwards. Very few people needed replacement of their immunoglobulin. Remember, the CD19 CAR Ts wipe out B cells at many levels. And so we thought, is this really possible? And so as we started using this over time, especially now, and I'm going to pick on John Hogan and Cavaletta, an LN patient with very refractory disease was dosed and experienced a grade 4 ICANS. This is a neurologic syndrome, probably on the spectrum of cytokine release. She did well. She was in the ICU for a bit, and then she was managed appropriately, and she recovered. Patients treated in the United States have not all gone into remission. Some have not even responded, and we actually have folks here. Amber is going to be here, and she has experience with this. Rich Fury has experience with this. So the panacea of 100% renal remission with no side effects is not necessarily what we are going to see going forward. Then you all know that the FDA released a statement in November of 23 regarding T-cell malignancies from the modified CAR T-cells. This was in patients that have been receiving CAR T-cells for malignancies. And you can see there were 20 cases with a denominator of greater than 30,000 patients. Is this a real problem? Well, we have experts in cell therapy here, and they'll be able to provide insights for us as to whether we think this is a real problem. But don't forget, these cells that we're using now are adenovirus transformed. However, we're also going to be talking about other ways to make CAR T cells that may not need viruses, that may be CRISPRed. And now, from the George Schett group, we have a new disease. It's called, and I'm going to have to read my slide, local immune effector cell-associated cytotoxicity syndrome, or LECATS. And LECATS, they hypothesize, is that when these CD19 CAR T cells come into patients with autoimmune diseases and they infiltrate the organs and they instantly kill all the B cells, you have maybe some sort of cytokine storm or some sort of damage in the organs that are particularly affected by the disease. And you get symptomatic problems. So you can see here, can you see my arrow? Oh, maybe not. Anyway, I put a little graph. This paper just came out in Lancet Rheumatology, and I indicate there the kidneys are involved. They had several patients who had kidneys that had developed AKI. So their creatinine went up, their proteinuria increased. This was transient. It was treated with glucocorticoids and it seemed to get better. So this is something we have to be aware of. And you can see that different organ systems were affected by this syndrome. And of course, this is all hypothesis generating. We don't really know what causes this syndrome, and we don't really know how severe it will be. Almost all of these patients had very mild AKIs. One actually had a severe AKI, and they were biopsied. They had thrombotic microangiopathy. So, despite what I just said, and this is a quote paraphrased from the patient who actually developed ICANS, my very first bullet point. This was given at the rheumatology meetings last year. The patient said, even though I was in the hospital, even though I was severely ill, I feel so good right now, I would do this again. And we have a patient panel here. We're very lucky to hear from our patients on what they want out of our therapies and what we can do working with the patients to get this. Okay, I'm skeptical, and I hope all the nephrologists in this room are skeptical about complete renal response in refractory lupus nephritis in 3 months. So on the left is the graph from George Schett. You can see at month 3, the proteinuria goes to 0 in all of these patients. And then one relapses, but that biopsy showed lupus podocytopathy, not lupus nephritis active. So I believe that resolution of proteinuria in refractory lupus nephritis is difficult to explain within 3 months other than hemodynamically. Okay, why is that? Refractory lupus nephritis suggests the patients have had it for a while and several treatments failed. An inflamed kidney develops scarring, as we all know, and nephron loss over time, especially in an inflammatory disease that's not controlled for some period of time, which by definition should be refractory lupus nephritis. So that leads to fixed proteinuria that will never go away by controlling inflammation. So how is this possible? And I've been asked this question a lot. I don't know the answer to this question. Hopefully we'll discuss this in some of our groups today, because this is a phenomenon that we're seeing with all of the CAR T treatments. But let's say the kidney can remodel. Why not? I believe the kidney can remodel over time. The heart remodels over time. If a kidney can remodel, maybe damage-related proteinuria can indeed resolve. Can it disappear? That I'm not sure about, but maybe it can get better. Can CAR T-cell therapy resolve kidney scar? That would be great. We need tissue. Can CAR T-cell therapy remodel the kidney within 3 months of giving it? That would be even greater. We need pre and post tissue. And with many of the folks in the room that we're consulting with, we are starting to put repeat biopsies into the CAR T-cell protocols to help try and answer these questions. And finally, the trajectory of the decline in proteinuria here in the CD19 CAR T was really, really good. But let me show you the trajectory of proteinuria in the study of the dual specific CD19 BCMA CAR-T. That seems much more likely to me. It's a mess, and these are, again, refractory patients. So is there any data to suggest what happens post-CAR-T? So this is taken from the BCMA CAR-T. They did a renal biopsy in one patient. All I have is immunofluorescence to show you, but I think the result is profound. And I'm going to tell you why. On the left, you see all of the immunoglobulins in a refractory lupus nephritis pre and then 6 months post-CAR-T. Okay. What you see is a little bit weird for an active lupus nephritis, as Isabel, one of my faculty members, tells me. Where's the C3 and where's the C1q? Okay, as nephrologists and nephropathologists we have in the room, we'll all agree that's a little bit weird. In active lupus nephritis, you would probably expect to see complement. Nonetheless, if you look on the right side, after the CAR-T therapy, you see that there's almost no immunoglobulin present at 6 months. That's phenomenal. On the right side is work that Anna and I have done with Valeria, and you can see the time course of resolution of immunofluorescence in patients with lupus nephritis, repeat biopsied over many, many months with standard therapy, and you see IgG in the red line. It takes years under normal conditions for immunoglobulin to go away. So if CAR-T cells really make immunoglobulin go away in 6 months, who knows what else they could be doing. Now, one little thing here. This is the only tissue I could find in the literature of a histology of a glomerulus. This is 1 month post-CAR-T, CD19 CAR-T, and this glomerulus really looks terrible. Okay? There's no suggestion this glomerulus is remodeled in any way. I'm trying to stir the pot. It's okay. You can all hate me or, decide which side you want to be on. Anyway, now I'm also skeptical about immune reset. Honestly, I don't even know what immune reset means. I thought it was when the immune cells repopulate, they're going to come back and they're going to be different and less autoreactive. And I thought that exploring the differences between B cell depletion with anti-CD20 and B cell depletion with CAR-T therapy may provide some insight. So I did that in my head. So as many of you know, neph and rheumatologists in the room, this is the phase 3 Regency trial. So it was obinutuzumab added on to mycophenolate versus placebo to mycophenolate. And this was a positive trial reported recently. And you can see, number one, these are not refractory LN patients. And number two, the remission at 76 weeks, complete renal remission was 46.4%. It was not 100%, nor was it at 3 months. It was at 76 weeks. Okay. So we have that. And I said, well, what's the B cell depletion like? The CAR-T cells deplete the B cells completely within a very, very short period of time. You can see on the left. And then these are the 5 patients in the first Chet paper. You see that the CAR-T cells decline fairly quickly, and then the B cells start coming back within 3 months. So peripheral B cell depletion is short-lived, but pretty profound with CAR-T cell. And on the bottom is the B cell depletion peripherally with obinutuzumab, and you can see that it's 90-some% depleted throughout the entire time the patients are taking the obinutuzumab. So we have short-lived B cell depletion by CAR-T cell that's very profound. We have long-lived B cell depletion by anti-CD20 that's very profound. So that looks the same to me, even better with the anti-CD20. So maybe the CAR-T cells that come back, the B cells that come back, are really profoundly different. And what we actually see is on the left, what you come back with mostly are naive B cells. And that's cool. Maybe the naive B cells are so naive that they're not really autoreactive anymore, and the memory B cells aren't coming back. and these other ones, plasmablasts, aren't coming back. Well, we actually have data that Rich and I published before. This is not from the Regency trial, but this is from the Nobility trial, which is the phase 2. So you can see that when the obinutuzumab is stopped and the B cells come back, what comes back are naive B cells. Okay, so that's not so different than the CAR T cell. So really, what's going on with the CAR T cells? Okay, couple things. Number one, we're targeting CD20. And we have some experts here in CD19, and should we be targeting CD19 instead of CD20? And why do I say that? And I hope I'm going to learn a lot about this from this meeting. But if you look at the B cells that contain CD20, it's a fairly small population compared to the B cells that contain CD19. The CD19 is on plasmablasts, and it's on long-lived plasma cells. It really disappears at the very end of this red line in the really terminally differentiated bone marrow long-lived plasma cells. So we get a lot more cells. So maybe it's CD19 that's the issue. Maybe that should be something we're going at. But if we do, why haven't we done a CD19 antibody in lupus? Well, we did. And Sarah's one of the authors on this. They tested a fully humanized anti-CD monoclonal antibody with a name that I cannot pronounce, obaleximib, that was stopped after the phase 2 data because the endpoints were not achieved. The graph here shows you the endpoint. This was an interesting trial. This was non-renal lupus. This was patients who had modest to severe extrarenal lupus. Their disease was brought under control with glucocorticoid. The glucocorticoid was stopped. They were put on this B cell drug or not. And then we looked, not we, they looked at when the disease flared again. And you can see that even though there was a suggestion of benefit with the B cell drug in the blue line, that was not statistically different. And so this study was stopped. But this is not the study that we've been doing with most of our B cell therapies, where we add them at the beginning like we did with obinutuzumab. So I think the question of can a CD19 monoclonal antibody replicate some of the effects that we see in CAR T without having to do cell therapy? And I believe, and Sarah would tell me, we are starting to study that in lupus now, but we haven't moved it to lupus nephritis yet. So hopefully we will, since we're all honorary nephrologists here. Okay, here's the thing. I think tissue is the issue. I think always tissue is the issue. And so this is the lymph nodes after CAR T treatment for autoimmune disease. And just look at this. At the top line is what a lymph node looks like. And you can see CD19 cells, CD20 cells, and CD138 plasma cells. And then post-CAR T, you see an absence of everything. And then post-rituximab, you see that we have not really done a good job at getting rid of the B cells. So clearly, rituximab as an anti-CD20 doesn't get in there very well and clean out the B cells in the tissue. Okay, I'm on time, actually. This is unbelievable. Look at the lymph node architecture after CAR T therapy. The lymphoid follicle just blows up. You see this, the post-CAR T, and you see what it looked like ahead of time with the lymphoid follicle. And the CD20 follicular dendritic cells go away, the PD-1 T follicular helper cells go away. It just blows up the lymph node and probably does this in the other secondary lymphoid tissues. And you see that after rituximab, that's not the case. Okay, so the CAR T cells are getting into the tissue and doing something profoundly different than we see with circulating monoclonal antibodies. And then what about the kidney? Well, this is a kidney after CAR T therapy. This is 30 days after CAR T therapy. As you see, I have not a smiley face there because there was no pre-treatment biopsy that was stained. But I guarantee that an active lupus nephritis will have plenty of B cells in the kidney tissue. So you can see that CD20 is gone. You can see that CD19 in the kidney is gone. This is an N of 1, of course. CD68, so monocytes, macrophages are still there. CD3 T cells are still there. Okay, so that's sort of cool. What about obinutuzumab? Well, we don't really have very good data on obinutuzumab, and certainly not in autoimmune diseases where lymph nodes have been biopsied. This trial called THERI was a phase 1 trial to look at transplant patients who actually had been making a lot of antibodies, so they couldn't get transplanted, so they received 1 or 2 doses of obinutuzumab to get rid of these preformed antibodies, and then when they went in to put a kidney in, they actually saw some of the lymph nodes and took tissue. And what I'm showing you here is that, and you're going to have to pretend you remember what rituximab looked like. The T cells on the bottom, OB doesn't touch, but the B cells, OB does a pretty good job of clearing out the lymph nodes of B cells, but not perfect. It certainly is not zero like we saw with the CAR T cells. And on the left are the graphs of T cells and B cells, and you see a lot of the lymph nodes went to almost no B cells. A couple did not. So maybe it's really the tissue penetration that we have to think about with some of the B cell therapies. So let me summarize in 2 slides, and then I don't know if there's questions or we go right to the debate. I don't actually know that, but debates. Okay, so you can't ask me any questions, which is actually great. So I don't have to defend anything I just said. Off-the-shelf CAR T cells are now becoming available. They're allogeneic. They're already in trial. They've been modified genetically to be hypoimmune, so they're not kicked out by the immune system immediately. There's other sorts of CAR cells, CAR NK cells, where we have a trial going on where we combine CAR NK cells with anti-CD20 to enhance the killing of B cells by the CD20. Most of the new protocols are trying to become less scary to those of us who are not cell therapists by reducing the Cytoxan and fludarabine preconditioning. And then we have another new category. It's not new anymore. It's been used in oncology for a long time, of bispecific engineered antibodies that bring B cells into contact with T cells. And these are starting to become in trial. And the results of these, at least by some reports, look pretty much like a CAR T cell without the CAR T. And they actually cause the same sort of side effects like cytokine release syndrome. So an interesting dilemma. And this is my little sort of figure. We have B cell depletion, and we can sort of decide now or dial up how deep the B cell depletion should be. We have the type 1 monoclonal antibody, which is rituximab, is sort of the one that you think about, does well peripherally, not well in the tissues. We have the type 2 CD20 monoclonal antibody, does better in the tissue, but not perfect, and does really well peripherally. I threw anti-CD19 monoclonal antibodies in here. I don't know where they're going to fall. I'm assuming they're going to take down peripheral T cells very well. I have no idea what they're going to do. We have the NK CAR, we have the T cell engagers, and then the CAR T cells, which provide total B cell annihilation. So I would suggest to you that we have good or excellent peripheral B cell depletion working in a population of our patients with lupus nephritis. Other patients may respond but flare later. Some patients don't respond at all. We have all of these tools to sort of dial up the depth of B cell depletion on an individual basis, but we need to understand who needs what. And hopefully we're going to talk about, you guys are going to talk about this in your breakout groups. How deep do we have to deplete B cells, and what patients are appropriate for that depth of B cell depletion? Or are we going to be left with, let's try an anti-CD20. That didn't work well. Let's move up to obinutuzumab. That didn't work well. Let's do a T cell engager. That didn't work well. And then finally at the end, after months and months go by and the kidney is toast, are we going to do CAR T cells? So it'd be really nice a priori to know what patient needs what therapy right from the beginning. And I know I've been seeing all the emails float back and forth. There are some of you who have methodologies to look for the depth of B cell depletion without all these biopsies, which I'm very interested to learn about. So thank you so much for your attention. I hope this sort of focuses what we want to talk about in this conference, and I hope it can be applied to things other than lupus, like membranous and podocytopathies and IgA. And so the first debate is coming up, and these are mini debates. So Roberto, you're up first.